deal, I think. Much, much easier. And of course, should we know that the prosthetic margin are located nearby the cementum animal junction, we don't need that anymore. So this is ideal for compromised cases where we really have to decide what to do. Which are the advantages? I'm going to show you now a clinical case in order to understand the process, the protocol of the B.O.P.T. Well, the advantages are many. First of all, in a case like this, I have recession. Probably is a passive extrusion of the tooth, and I have exposure of the root. And also, if you look carefully, we have a gingival color changes, right? So I'm thinking, yes, I can still do a chamfer because I can be minimally invasive, I can be nearby the gingiva, the anatomical and clinical crown still coincide, yes. But the soft tissue is not thick enough. And again, how can I be predictable and in order to decide which kind of soft tissue I'm dealing with? Is a thin soft tissue? Is a thick soft tissue? Do you know? I don't. Actually, I don't. I will show you. We don't have time, but I can show you an article that they demonstrate that in the 25% of the cases, we don't know exactly which kind of biotype we are dealing with. So, in a case like this, even if I can still go through the chamfer, I prefer to go through the vertical preparation. Because through the vertical preparation, I can also have a beautiful response from the soft tissue, and I can demand my soft tissue to get thicker and thicker. And when I got thick tissue, well, I won't have any more color changes of the gingiva. And the first question, anytime we do go through the B.O.P.T, is how deep is the bone below gingiva? So, in the protocol, anytime we have to touch the teeth, we should go through the probing, understand where is the bone, try to understand, but I don't know if it's easy to do it when we're dealing with a thin or thick biotype. But it doesn't really matter with the B.O.P.T, because with the B.O.P.T, we can achieve a biotype conversion. I mean, we can expect the soft tissue to get thicker, which is amazing. Because anytime I got a thick tissue around my tooth, my veneer or crown, or around my implant, I've got the natural barrier that protects my tooth and my implant from the external world. So for me, manage and manipulate the soft tissue in an easy way is fundamental, is mandatory. How deep is the bone below gingiva again? And when we remove the crown, you can see, is the soft tissue here thin or thick? What do you think? Is the thin tissue? How many of you think is a thin tissue? Yeah, I think so. I think so. Then I will show you that it can be thick later on, without any surgery. So, which biotype? Thin, normal, thick? Well, yes, probably thin, but I don't care anymore because I know I can have a biotype conversion. And let's go through this. I try to measure it, and when I go with my bore into the sulcus, what I do is to remove the remain of the chamfer. I just want to have a vertical wall where I can still think which is the final positioning of my crown margin. It's very easy. So we get into the sulcus with the bore. We do have a gingitage as well because we touch in the gingiva. We have blood as well, but patient, believe me, don't go to hospital. They don't die. They're safe. And they don't even realize that we are touching the gingiva, okay? So for some periodontists, it could be like, what you talking about? Sto ti dieleješ? Nothing. The alternative was a connective tissue graft. What do you think? Is more aggressive a connective tissue graft or getting with the burr gently into the sulcus and maybe induce a little bit of blood? Like Mario before showed you a beautiful case on the palatal side when he got deep inside and he was bleeding, but after a while the gingiva was perfect. So you can invade with your burr the sulcus. Nothing's going to happen. So we go through, see, we go through the process, removing all the chamfer. We can touch the gingiva. That's why I don't like the burr with the polished tip. It doesn't make sense to me because I really want to touch the gingiva. And when I do this, I can polish them, and after that, we have, of course, a kit of burrs if you're interested, but you can get the code and buy it one by one and make your own kit. It's very easy. At the very end, we need 3, 4 burrs to do that. It's not important. The B.O.P.T is not about the vertical preparation. You need the vertical preparation in order to achieve the final results with B.O.P.T. But it's not about vertical preparation. So the key to understand the B.O.P.T starts from the provisional. After the preparation, after we've been invading the sulcus and we removed all the horizontal components, then we have a straight wall, vertical, 3/6 degree. And what we can do, we get the provisional and we go through the relining of the provisional, like we do with the chamfer, but without the limitation of a finishing line. We go relining our provisional, and with the resin, acrylic resin, okay, not bisacryl or other stuff, acrylic resin, we get into the sulcus. So we want to read apical into the sulcus, no problem. We do this, and then we have the provisional. And as you can see, we have the apical part of our preparation here. This is the apical part. It's not a finishing line, it's a finishing area. Okay? With the chamfer, we have a finishing line where we think we're giving to the technician the information to start with the crown. In this case, we just have a finishing area. And we want to create a thick margin because the margin of the crown is the landing area for the soft tissue to adapt on. So this is key to understand the B.O.P.T. So I mark my apical part, then I go through the laboratory process. I want to fill the apical part with resin, and then I create a thick margin of my crown. See, here. I fill it up with flowable resin, or it can be flowable composite. So I create a thick margin, but of course this margin is too apical. So I want to also to shorten my provisional. And then after that, I remove the exacts, I shorten my provisional, but I still don't have the information. Where is the gingiva? How deep I've got into the sulcus with my margin? But I go back to the patient at the church side and I place the provisional intraorally. And in this case, see, I reduce the length of my provisional in order not to be aggressive, not to push too much the gingiva. But I still don't have this information. So I just need to do that and then go intraorally. And intraorally, I have a surprise. If I'm a little bit skilled because I know what to do, I can get very close to the final crown margin. If not, doesn't matter, because I can still make a double check and make sure that the margin will be where I want the margin to be. So we have 2 lines here. One is outside. I draw the line just to show that I want the gingiva to be there and symmetrical to the other incisor, central incisor. There is another line you can't see because we have the blood. But there is another line, juxta. When I remove the provisional, as you can see, we have the juxta line, kind of, and the other line, which is the line where I want the soft tissue to be. So in the first place, when I do my preparation, I'm not expecting the gingiva to get coronal because it's too thin. You told me before, when I asked you, what do you think is this gingiva, thin or thick? And somebody told me, yes, it's thin. It's very thin gingiva. So how can I expect the thin gingiva to get coronal? So the first thing I want to do with my gingiva is to create a thicker tissue. This is what I do. So I can remove this part, apical, and be juxta. I can be at the gingival level with my provision. I never, ever invade the sulcus. If the gingiva is apical, I just get apical with my provisional at the gingival level, no more than that. Then, of course, my goal is to get coronal to the second line. How can I do that? Well, I just have to be patient. So I just finish my provisional. As you can see, the provisional has got a thick margin because the margin is the landing area for the soft tissue to adapt on, okay? Like we saw before with the over contour on natural teeth. We have a cementum enamel junction and then the over contour. And the gingiva probably respond to this anatomical situation in a specific way. So we get this landing area, and then we just have to wait. We wait, like as a protocol, 20 days. And in the 20 days, the soft tissue will get thicker. Not coronal, just thicker. When I got thicker tissue, I will show you, I can, after 20 days, shorten my provisional and recreate a symmetrical line according to the other central incisor. But I have to wait at least 20 days. It's a biological time, shortest time, but enough to expect the soft tissue to get thicker. After that, I shorten my provisional. And what happens? The soft tissue will follow me. So for the first time, I don't have to follow the finishing line. I don't have to follow the soft tissue, but I'm expecting the soft tissue to follow me. And then, day by day, as you can see, the soft tissue gets closer to my new margin of the crown, which is to me the new prosthetic cementum enamel junction. No more than that. So this is key to understand the process. And day by day, the soft tissue will adapt on it, will settle on it, will be perfect. The more I wait, the better it is. After more 20 days, I want to get my soft tissue more coronal. Okay, I can shorten again my provisional. And after 10 days, 2 weeks, depends on the patient, depends on the biotype, it depends on the quality of the soft tissue, the quality of the hygiene. There are many, many different situations. But for sure, if I'm patient, day by day, the gingiva will adapt to the new shape I'm giving to the crown margin, to the new prosthetic cementum enamel junction. And before the final impression, I'm asking you again, is the soft tissue thin or thick? Thick? Yes, I think so. Now I have a thick tissue. Before, nie znаю. Może być thin. Now, nie znаю. Thick. So I have kind of, I don't know if I'm allowed to say it, a kind of biotype conversion. So I have gingival thickness, and when I have thickness of the gingiva, I'm pretty sure I'm comfortable because I know that the thick tissue is going to be stable in time. So these are the biological advantages. So from here, if you remember, we get here. It's a complete different situation. Now I'm comfortable. The chamfer there, now I don't have the chamfer anymore, but the chamfer is in the crown itself, in the margin of my crown. So I go through the simplified adhesive cementation, and well, Mario, Davide Cortellini, Angelo Canale are friends, and I've been following the protocol from the article, Simplified Adhesive Cementation. So how can I do this? I can't place the clamp, I can't do traditional adhesion, but I can do my best in order to isolate the field with a rubber dam, kind of Brazilian style or whatever, Turkish style, but it works. You can work with cords, cottons, try your best to make the isolation, and then go through the cementation. And of course, when you do that, it's kind of predictable. You can use different kind of cement, self-adhesive cements. Very, very easy. And the funniest thing is that So for some people, they might ask me, but if you do this, then if you have this silicate, for example, you might break the margin of the silicate. No, not at all, because it's a monolithic crown. I want to have a thick margin because I'm removing the chamfer, and the chamfer is in the crown margin itself. So I'm working with a thick margin, and the thick margin won't break. I'm safe. So monolithic lithium disilicate, simplified adhesive cementation. I do light cure for a few seconds. I remove the sacs, air block, and I'm done. I will show you then, in other cases, if you blow the air, the gingiva will rise, and you can see 360 degrees that your margin is juxtagingival, and you can check if you have cement. So it's very predictable also, the cementation. We go through the air block, wait. This is day 0, I don't like it. And of course you can make mistakes sometimes, but it's kind of nice mistakes. After a few days, after a few months, the gingiva will adapt on new shape and will settle on the new Burgess profile of the crown. Okay? So this is what happens. And believe me, if you're gonna try not on a central incisor, but if you're gonna try on Monday morning on a premolar of your papa, of your babushka, you can be very minimally invasive, and for sure, you're gonna see beautiful soft tissue. And your babushkas will be so happy, because the alternative was a connective tissue graft. So you decide what to do, right? 6 months later. And which is the real power of B.O.P.T? For dramatic cases like this, for example. What can I do in a case like this? Yeah, you might think Yakultoi, I can do crown lengthening, I can do whatever I want. But at the end of the day, all the other protocols are difficult. So should I prepare for a yeah, look at the route. Well, the alternative, yes, we have an alternative. Extraction, implant, fast, and money. Why not? You can decide, but I'm still from the patient side. I have an ethics, and I think like my patient is my babushka. So I don't like this kind of approach. I don't want to be aggressive. And if you can see, I can do my build up, I can do my vertical preparation, and in a case like this, I got close to the bone, and nothing happens. The bone is still there. I don't have recession. I don't have all the, you know, devil stuff that happens around the tooth when you touch the tooth in such an aggressive way. Not at all. So we've been learning for books many things, but today I think we should also change our point of view, our vantage point, and look at the books from a different point of view and think on our own. So anytime I do this, look at the cord. Do you think that the cord is going to be aggressive and responsible for the recession? Do you think that? Of course not. So look at this, the remains of the tooth. The alternative of this is crown lengthening, and after crown lengthening maybe extraction, because you get to bifurcation. You decide. So I do my impression, and the impression is quite easy. I need a black cord into the sulcus, a green one to open the sulcus. I can take a digital impression, I can take analogic impression, it's about the same stuff. What I can do now, I can place also the provisional intraorally, wait a few minutes, and ask the patient to close gently. So I push the cord and I open the sulcus. And when I do that, I can take a beautiful impression. It's very easy. I like the silicone better than polyether, because the resilience of silicone is better than polyether. It's not more precise, but I can get very precise impressions. And then your technician know better than me that when you work vertically, you can get higher precision compared to the horizontal preparation, chamfer or shoulder. So I get the final impression, analogic impression, and this is not the chamfer. This is the epical part of my finishing line, okay? I don't have a chamfer anymore. You don't have to think like chamfer. Think Chamfer men, chamfer ladies, please, don't think like that. Just think that you got a finishing area and you got apical to the point where you want to place your crown margin because you want to see apical. So this is the impression and this is the final crown. Do you think that this crown is going to break when I go through the cementation? Look at the margin. Okay? So it's impossible. It's very safe. And then this is the final crown. And if you look at the X-ray, do you think this is my technician was sleeping bad the night before and it was not precise? No, this is the over contour of the crown margin. This is the over contour where I'm expecting the soft tissue to have a response, which is symmetrical to the over contour. And then after a few years, it's still there. The gingiva is there. The babushka is happy because no surgical approach, no crown lengthening, not orthodontic extrusion. It's perfect. Normal tooth, very easy case. Okay? So, the real field, the real power of B.O.P.T is that when you have compromised teeth, because they've been prepared already for a chamfer, they've been prepared already for crown open margins, crowns, and so on. So when you remove all this, you find yourself in trouble. Then what can I do? And the alternative to invasive, aggressive protocols is the B.O.P.T. Again, one more case. I never show this case because if I have some periodontists here, they might try to kill me. And they think, what are you doing? Well, I show you now. It's an old crown. Again, babushka. If you look carefully, what can I do here? Orthodontic extrusion. I don't think so. Look at this. Chamfer. I don't know. Really don't know. Extraction and implant. Even better. But as an alternative, I can go through kind of aggressive preparation. With my bore into the sulcus, I remove all the horizontal component, I clean up everything, I do my gingitage, and look at this, the patient is bleeding, but he's still alive. And again, this is an alternative to a more aggressive procedure. Okay? And every day we have to deal with things like this. And then I get inside and clean up and polish my abutment, my tooth abutment. And look at this. And after 2 weeks, 3 weeks, I will show you. Now you might think, oh my gosh, what have I been doing? What am I doing now? I'm in trouble. Well, look at the blood. Unbelievable, no? How many periodontists there? Show me. I know you want to kill me, right? But after a while, I will show you that the patient is still alive. And what I do, again, with my provisional, I do the relining. And again, I want to read apical. Again, I'm going to fill this area. See, this is the apical part of my finishing area. And I want to fill the area between the crown, the external part of the crown, and the apical part. I fill it up with flowable composite or flowable resin. And then I have to remove the exacts. And then I have to shorten my provisional. And, well, it's very easy, you know. I work a little bit at the chair side nearby the patient. Maybe I have a little laboratory nearby my office. But the alternative is to be at the chair side doing aggressive stuff. Or being on a table, sitting, listening to radio, and prepare your provisional. You decide what is best for you. And look at this. I go intraorally. I check the crown margin, and I want to know how deep I'm into the sulcus. So I never invade the sulcus. How deep I'm into it? Well, yes, I'm a little bit too deep, so I still have the option to shorten my provisional now, okay? And respect the biological width or the new biological width I'm creating with this procedure. And again, this is what happens. I do it. I polish my provisional, I wait a little bit, and after 20 days, it's like a new tooth. The alternative was the extraction. Okay? So this is the power of B.O.P.T. And then, look at this at the soft tissue, 20 days, not 2 years. 20 days, not 6 months, 20 days. So we have a new contour, a new gingival response. The soft tissue is going to adapt to the new crown margin very, very easily and predictable, with predictability. And again, impression, black cord. Of course, you have to be skilled, you have to be gentle because the soft tissue is still healing. You can't be aggressive. But gently you place the black cord into the circles, then you place again the green one. You place the provisional, wait a little bit of compression. Sometimes you might have a little bit of bleeding or circular fluid. Okay, wait, remove the cord, be gentle, do it again. Takes 5 minutes. Then you get the impression. And with the impression, we get all the informations. We don't have any more the information for the chamfer. So your technician might be lost because where is the chamfer? Where I have to start my crown? This is another problem, right? Because everybody asks me, well, yeah, but what can I do with my technician? How can I communicate with my technician? Well, it's very easy, actually. You should follow the anatomy. And especially in a case like this, in a single crown, you have the neighboring teeth that gives you the informations. So identify the finishing area. And again, with a pencil, I want to mark the gingival level. Then I remove all the gypsum because I don't care about the gingiva anymore. I know only this, that the gingiva is nearby the red line. Then if I do, for example, in this case, I've been doing a digital protocol with a scanner. So I want to know where is the soft tissue level. I want to know where the apical part or the finished line. And I have a finishing area in between. No, a finishing line, a finishing area. So in this case, what I can do, very easily, I have to remove a part of it if I go through the scanner. So I tell my technician, for example, this is not an aesthetic situation, so just create the crown margin 0.5 apical to the red line. And my technician is going to follow the red line 0.5 millimeters more apical. That's the only thing he has to know. And then he has to look at the nature and recreate the natural emergence profile of the crown. So I ask him to go 0.5 and is supposed to remove all this part. If you remove this, then you can scan the abutment, and after that it's going to be very, very easy for you because you got only the information you need, where I'm supposed to place my finishing line. And the finishing line is in the crown itself. So this is my new finishing line. This is my new chamfer, which is into the crown itself. Very easy, huh? Very easy. So according to that, I go through the digital, and I have my monolithic crown. And again, after that, what we can do, we go through the cementation. Sandblasting, etch with the high fluoride 5% for 20 seconds. Then silanization, cementation. I can use multi-link, I can use whatever you like. Self-adhesive cement, Relix, Smart Sand, whatever you like. And what's interesting, one question people ask me, but how can I control the cement? Well, look at this. If you blow air, you can see perfectly because you're not into the circles, but you're used to. As much as you were with your chamfer. Yes, you are a little bit more medial, but the apical coronal level is the same, or at least it's not the same actually. It's where you want the gingival level to be. With the chamfer, you cannot get this result. So you got this, very, very easy, okay? And then after years, the crown is still there. Babushka is happy. Very, very happy. Also, my ex-wife is very happy, even if it's my ex-wife. So from year to year, 6 years later, what can I say? This is an alternative to a more aggressive treatment, okay? Now, I want to be clear about this. Don't misunderstand me. I'm not talking about vertical preparation instead of a chamfer on beautiful natural teeth. This is a mistake, both for the chamfer and for the finishing, for vertical preparation. Still there, 6 years later, 5 years later. Okay? So, I think it's a powerful tool. And one more concept. We have the concept of adaptive forms and profiles. If you look carefully here, what can I expect from the soft tissue? I can expect the soft tissue to be symmetrical to the new crown margin. What do I mean for that? I will show you now. I feel like seagull wings. The more convex margin of the crown, probably the more convex profile of the soft tissue I have, like in a seagull. Understand? So adaptive forms and profiles. And I will show you now how it works with a drawing. This is a natural tooth. And this is the chamfer. As you can see, the chamfer is exactly where I want the chamfer to be. In an ideal case, is into the enamel. But again, even the vertical preparation is at the same level. So in an ideal case when I have coincidence of anatomical and clinical crown, I can work at the same level. But I have a difference now that I can also decide to be more coronal or more apical, and I'm expecting the soft tissue to follow me. Plus, since I removed this little part, I have thicker tissue here. Because another rule is that according to the emergence profile, according to the angulation of my margin, I can expect a thicker tissue anytime I work with a thicker crown margin. From here, for example, look at this. But it's really like that. If I have a very thin margin, like we did in the past in the SSSR time, when we did vertical preparation with a very thin margin with metal, then we have a very thin gingiva. And we've been doing this preparation for perio problems. But here we can still work their way, but working on the margin. Thicker the thicker tissue response we have, like symmetrical, like a seagull wings. It's very interesting, right? And again, I'm going to show you a mistake I've done. That was my first case I've done in the central incisors, in aesthetic area. 205, I think, 14 years ago. So I decided to go through the vertical preparation. It was a little mistake, but from there you understand and you can communicate with your technician better and better. And it's very difficult then to make a mistake. What I've done, after I removed the crowns, I removed the horizontal informations. I want a vertical wall. That's what I've done. Then I did all the procedure with my provisional. And then after 20 days, I have beautiful tissue. I've been working perfectly. But still, I wasn't communicating very well with my technician. So I did a good job with my provisional because I was there at the chair side. And what I've done with my provisional, I create two provisional symmetrical. And the gingiva was symmetrical. And then what happens? 205, I will show you after 14 years. I don't have such a beautiful response. It's okay, but there is no symmetrical architecture here. Little bit is nothing actually, but you can demand your technique and your protocol to be perfectly symmetrical. What you have to tell your technician, please do me two crowns, since they are two central incisors, do them perfectly symmetrical, with exactly the same crown margin, exactly the same angulation. If you do that, the soft tissue is not clever. It's going to adapt to perfectly symmetrically crown margins. Okay? So it's acceptable, achievable, but not what I want. And then you start thinking about this and say, well, I can do even better. So 245, 219, the soft tissue stable. I'm happy, the patient's very happy. But I'm thinking about what can I do to make my work better and more predictable. And now I'm going to show you one more case. Have discrepancy here. And probably as a chamfer people, you think, okay, I'm going to raise a flap. And you know what? While I raise a flap, I'm going to do a crown lightening here. I'm going to remove the exact bone, so I have two symmetrical crowns. Perfect. And maybe if it is a natural tooth like this, I can also cut the gingiva and the bone on the beautiful natural tooth, just to make it symmetrical to the other crown. Right? We've been doing this in the past. I've done the same. So what I can do now, look at the case. And of course the crown is more apical, and we have an apical positioning of the gingiva. So what I'm doing, I remove the crowns, and well, look at this. Again, the chamfer. So you chamfer people, how can you expect to do the chamfer here? Tell me. The remains of the tooth is nothing. If you go through the chamfer, you for sure you have to get apical to get a good quantity of residual tooth. So I don't like this. So there, in my opinion, if I go through the vertical preparation with the build-up, then I can get the ferruli effect on the residual part of the tooth without removing quantity and quality of the remains of the tooth. So I can go through the minimal preparation. I can still place my green cord, open the sulcus in order to read apically, go through my relining again. All the cases are like this. I've got plenty of cases to show you. I go to the relining again. I go apically. I want to get the finishing area, not the finishing line, the finishing area. I want to read. And again, this is the apical part of the finishing area. Then I have the external part of the crown. I'm going to fill this with flowable composites or acrylic resin. Okay? And then I have to remove the exacts and shorten a little bit my provisional. How deep? Well, I have the opportunity to double check intraoral again. So I finish my provisional. To be more comfortable, I split them together. I splint them, not split, splint. And then I go intraorally and I mark with a pencil again the gingival level. And as I told you, if you have to be skilled because you're used to it, you get very close to the final positioning. And again, I can decide to shorten if I want. I want to be juxta. I don't want to get not even for 1.0 millimeters into the sulcus, if I want. And what I like about this, then after a few days, I still have to work on the gingival level with my provisional. But if I know how it works, why should I wait? The gingiva now is stable. I can take the impression easily, even if the final gingival architecture is not perfect. I can tell my technician to create two symmetrical crowns, and then after 10 days, 7 days, I can cement my crowns, and I have symmetrical gingival response. So I know it works. The first time you do it, please don't do it, because I want you to believe it. So you have to, I say, you have a learning curve. So wait a little bit with the provisional. Get to the finals with the provisional. But you can still, if you are skilled a little bit, if you got experience in this, avoid to wait so a long time. And you get to the final positioning just because your technician knows now that he's going to create two beautiful crowns perfectly symmetrical. Okay? And then after 2 years, better and better. What I'm scared of are the neighboring teeth that can get through the recession, not my crowns. Not because I'm clever, because in this space, I know that I have thicker tissue. And when you have thicker tissue, the gingiva is stable. So I like to think that in this area, right here, where I removed a little part of the tooth, the chamfer, here, right here, I have thicker tissue. I create a chamber where the soft tissue get thicker. So I got thick tissue. I got a huge membrane, a huge barrier for my tooth to the external world. I think it's interesting if you think like this. So don't think like tooth preparation. Don't think like which kind of materials I have to use. You can do it with disilicate, with zirconia, but even with PFM, porcelain infused to metal. It's up to you, because if you get a thick tissue, you will never see the dark color of the gold, of the chrome cobalt, or cobalt chrome, whatever. Because you got thick tissue and it's stable in time. Okay? Now, we can also expect, anytime we work like this, that the gingiva will adapt to the new shape and form. Okay? So think like anatomy. Just look at talk to the technician and tell your technician, you know the anatomy. Just duplicate the anatomy. Just copy the anatomy. You got all the information you need. One more case, a little bit more difficult. And again, I start my diagnostic with the smile design. Now we do a 3D smile design, of course, and we are kind of full digital. But it's still nice to work with pictures in order to communicate with the patient. And what I say in a case like this, it's kind of easy case, but here on the lateral, we have an apical zenith of the lateral plus gingival color changes. And again, I'm asking you, yes, tell me how to solve this problem, please, because I'm very curious. If you do the champ, I'm really bloody curious. How can you solve the aesthetic problem here? Because I don't know. Actually, if I go through the chamfer, I really don't know. So I do my diagnostics, I do my preparations, the veneers, minimal, no prep veneers. And on the right side, it's quite easy because the gingival architecture is quite correct. I don't have to make any changes. Predictable, fast. On the other side, I have this problem. But now it's too late to work with the B.O.P.T. I cannot work with my provisional anymore. It can happen. A lack of information with my technician. I think is not important for the lady. But as soon as the lady sees beautiful teeth and she says that the 22 is apical, doctor, što ti djelaješ? Nije ravica. I want you to do something. And so what can I do? Go through the provisional? No. I can modify the shape, the length of my crown without harming the quality of the crown. I can still ask my technician to recreate an over contour, make my crown shorter, and of course, in a case like this, I cannot expect the gingiva to get on this, to adapt on the new margin. It's too much. It's a big jump. So I have to help the gingiva. But again, this is over contour. Is this devil? Is this responsible for recession? Not at all. This over contour is a new prosthetic cementum enamel junction. What do you think, Mario? So to me, it's only a new contour, a new prosthetic cementum enamel junction. So I want to help the gingiva in a case like this because I didn't have time. I'm missing actually the time to work with my provisional day by day. But if I do a little bit, a little connective tissue graft in a case like this, I can still achieve a nice result. And as you can see, very little connective tissue graft, just like a few millimeters, only in this area. See the over contour? So the over contour is not responsible for a bad periodontal response to me. The over contour is something that we know from the nature. We know that it's biologically oriented and it's going to help us because it's going to be the landing area for the soft tissue. So we go through the bi-type conversion with a little boost, of course, connective tissue graft, wait a few weeks, few months, and then as you can see, the gingiva again, I've been helping the gingiva, of course, but it's going to adapt to the new shape of the crown. Easy, no? I've done it as well. I don't like to do connective tissue graft. I've been missing this part, but I can still achieve a good result without taking another impression, without asking my technician to make a new crown. Because I'm working on a vertical wall, so I can still do it before the final cementation. And then, day by day, the gingiva gets better and better. So I'm pretty sure I can achieve beautiful results with ease and predictability. Now, as you can see, the line is, the margin is coronal to the line in between the central incisor and the canine. Before it was apical, few millimeters, but believe me, 2 millimeters in a lateral is the 30% of the length of the lateral. So it's a failure from an aesthetic point of view, right? So the concept is adaptations, forms, and profile. Anytime we get a new finishing line, which is in the crown itself, and we modify the crown margin, anytime we do this, we can expect the gingiva to adapt to the new shape we're giving, the new informations we're giving to the gingiva with our crown margin. Easy, right? And after years, the gingiva is still there, coronal to the line from central incisor and the canine. You can do different, but this way you got very nice aesthetics with ease and predictability, which is what I like. When anytime I'm tired, I was talking to Mario before, I'm tired of working at the church side. So when anytime I work at the church side, I wish I could work with ease and predictability and be happy and relaxed. So I don't like to go through complicated process. I don't want to be Crutoy anymore. I want to be, my life to be easier, and especially for my patient. So which are the advantages of the B.O.P.T concept? Of course, we can also work on the frontal area in complicated cases and recreate acceptable or nice gingival architecture without any surgery. In a case like this, I got through my diagnostics in the first place. I've been deciding the shape, form, position of the teeth, and also of the gingiva. But I'm not worried about the gingiva anymore because I know the gingiva will follow me. So I remove the crowns, and how can I expect to go through the chamfer? I've done chamfer for 15 years of my life. And then when I start going through the vertical, I say, what have I been doing in the last 15 years? Wasting my time in complicated process, in complicated protocols. Why? Now I have the freedom to remove everything, go through the vertical preparation, prepare for the implant in positioning, and as you raise a flap, because I need to raise a flap to place the implant, as you can see, I have vertical walls, where again, I can decide where to place the finishing line of my crown, because I got a finishing area. And I can still decide which is the best position for my crown. And I know that the soft tissue will follow my crown. So I place the implant, and then even with the implants, I'm working with the emergence profile of the provisional, both on natural teeth and in implants. It's the same. We have a landing area where the soft tissue will adapt on. And if you look at the central incisor on the implant, day by day, the gingiva will grow on it, will adapt on and settle on it. Day by day. And when we get close to the finals, we can take the impression. Because then we know that if we get through the finals and we cement ceramic crowns, the healing will be even better. So from here, I recreate the convexity just with a roll technique, without any connective tissue graft. I've been utilizing the gingiva I already have in a place. Why should I and cut the palate of my patient? And they come to me after a few days, doctor, what have you been doing in the last, on my palate? It's hurting a lot. Nije rabica, nije nada. So I just work in there, and I recreate the convexity, and I go through the finals. Take the impression, And my technician is working with me, but at this point, technicians know that the gingival architecture I've been recreating with the provisional is what I want. So he's following the rule. I will show you in the next case. He knows what to do. It's very easy. You don't have informations anymore, but you don't have, and then maybe later when I finish the program, I can draw you something in order to understand that anytime you do the chamfer, you think, or your technician think that he's got the information to do the ground, but this is not true. This is not true at all, because he's been losing all the informations, and I will show you, I will demonstrate it to you. So you go through the final grounds, and no more than that. After the day zero is already almost close to the final aesthetic outcome I want the patient to be. The day zero. Then, the more we wait, the better the soft tissue comes. So this was the starting point, and these are the finals. See, you can really recreate a nice gingival architecture without being aggressive. And one more case, more difficult. What have we been doing here? Okay, I need to change the smile of the lady, but if you look carefully, we have problem. Well, compromised teeth. Part of them were severely damaged. I had to remove a lot of composites. I have to do build-ups. I decided to go through preparation. Rarely, but I have to. I have to do this sometimes. And what I asked my technician, I asked them to do for me a provisional. No regards for the gingival levels. I asked them on the model to recreate a beautiful gingival architecture according to the positioning, to the smile design and shape, positioning, form of my teeth into the framework of the lips, into the framework of the face. So I do this. I asked my technician to recreate on gypsum, not on the patient with anesthesia and the blade, on gypsum. I asked them to do the gingival architecture, do my provisional, and then comes the time to place the provisional. Before that, I've been doing my mock-up in order to have the compliance of the patient. I want the patient to make sure that the patient is going to meet the expectations. So I want to, communicate with the patient. So the mock-up is fundamental to me. The silicone guys, to be minimally invasive, even during the preparation, to me are mandatory. I want to work like this, because I want to be very minimally invasive, even if I have to prepare. And after 2 weeks, with the provisional, I reestablish quite nice gingival architecture. Just after 2 weeks, no crown lengthening, no rising a flap, nothing. Just working on gypsum. And of course, preparation of the tooth, vertical preparation. She was, I know maybe somebody already know this, but she was a lonely lady, and now she got a boyfriend. So sometimes the smile can change your life. And then when you look at the impression, there was the day zero, and how we get to the final with the impression? Well, it's very easy. How do I get to this point? Which are the information I have to give to my technician? We start from the impression, the day zero, when I'm sure that the gingival architecture is what I want, and I'm meeting the patient expectations. So I just go through the impression, and this is the model, exactly like in the intraoral aspect. And in this case, I'm utilizing a Geller model, but you can have also a unit model. It's up to you, and you can remove the gypsum. I like to work with the Geller, but then when it comes the time to get and check the contact point, I want a unit model as well, okay? But this is an analogical approach. Why not? And again, I just want to know where is my gingival level. Then I remove the abutment after I know for sure which is the gingival architecture, because this is the information I need to give to my technician. So I have to understand from the apical part of the finishing line to the gingival contour. I have to understand in between the finishing area which is the position of my crown margin. And it's kind of easy because this is the finishing area. It's very, very easy for me because I can tell my technician, please go 0.5 into the sulcus apical to the red line, which is the gingival margin. So the technician is going to make this and with a controlled invasion of the sulcus. All right? Very easy. Which is the anatomy. Technician should know the anatomy. Otherwise, please change the technician. Because that's the first thing. I go often to the laboratory because I have to learn from technicians. Because a good technician knows the anatomy, like us. Every day he is working with the anatomy. So he knows what to do. And of course I'm giving him information. We've been working with the provisional. We have all that we need in order to recreate beautiful crowns. This is what happens, and it's very, very predictable and very, very easy. After 6 years, the gingiva is still there. What I like about this, and believe me, I'm not here to sell you air. What I like about this is that if you go through this, you get thicker tissue, and after years you get surprised because the gingiva is still there. Never happened to me in the past when I did a chamfer. And then I was accusing the cord, I was accusing the impression, I was accusing the technician, I was accusing myself because I didn't prepare a good chamfer. What's wrong? Why I have recession? And I had failures, aesthetic failures. With this technique, never happened to me to have recession. Never. If you contact me on Facebook, you do a preparation on Monday, and after 1 year you have recession, I come to see what happened. I come to Russia on purpose to see what happened because it's impossible. So from here, lonely lady, boyfriend, now she's married with children. It's true. It looks like a joke, but it's true. Okay? So we can also, what time is it? At what time we have a break? 10 minutes? Super. Again, we can also work in a B.O.P.T with a different concept, with no prep as well. And I have many cases, mid-age patients, that they want a nice smile, they want to recreate a vertical dimension, for example. So what can I do in a case like this? No prep veneer? Yes, I like it. Is this a compromise? Yes. Of course. We have to decide what to do in our life. You can go through a minimal preparation, you can go through a big, huge preparation, or in specific selected cases, you can decide to be no prep. But of course, you still have compromises. So, in a case like this, for example, I need to work on the vertical dimension. I need to work on a new shape, dimension of the teeth. And of course, I need to work on the cervical area. Here, I have problems. It depends on the case. In a specific, the patient didn't care about gingival architecture. And if you remember when we do the B.O.P.T, the first thing to do, X-ray, pictures, but also sounding. We should know how deep is the bone below gingiva. In a case like this, the dentogingival complex was less than 3 millimeters. That means that sulcus was very, very little, as a thick biotype. The bone was right there. So if I go and try with a B.O.P.T, no prep B.O.P.T, to get into the sulcus, I might have trouble. I might have problems because I'm invading the sulcus. So even the B.O.P.T has got limitations. We always have to think about the biological width. Also, I have to know how deep is the bone below gingiva. And what I do in a case like this, I have limitation, yes, of course. So the patient not only wants to cover this, but he wants longer teeth. Because if you look carefully, when he smiles, or when he's talking, you don't even see just a little bit of the teeth. With a big smile, the teeth are too short. It's like a horse. He's biting like a horse. So I had to work on the function first. And what I do, diagnostic pictures, then we have the mock-up, and and then we go through the finals. And again, here, I've been forcing the cementation, which is very difficult, I think. When we do no prep, it's very difficult because you can really damage the soft tissue. You can really, you can be very aggressive in order to have a pure adhesive cementation. It's not easy at all. But what I do, anytime I can, I place the rubber dam and see again, this is the cementum enamel junction of my patient. So if I know now that the key to understand the B.O.P.T, I also know that if I place a veneer without touching the tooth apical to the cementum enamel junction of the patient, I may expect a soft tissue response. I can close the diastema, I can get a little more apical, somehow, 0.1, 0.2 millimeters, little bit, without surgery, but you can still do it. So this is the cementum enamel junction of the patient, and then this is the new veneer with a new prosthetic cementum enamel junction. Okay? Very easy. Well, it's a magic stuff, not at all. Do you have limitation? Yes. But it's my philosophy. I prefer not to touch a tooth for selected cases. I've got cases where I have to, but I've got cases where I can choose not to do it. It's up to what you think, to what you want to get from your patient, okay? So you go through this, and what's interesting about this, I recreate a new prosthetic cementum enamel junction. And very easily, under rubber dam, pure adhesion, bonding procedures, I go from here to here, without manipulating the soft tissue. Because when you don't need it, when you don't want to, when the patient doesn't want that, why you have to do it? It's got a healthy tissue, healthy periodontal, perfect biological way. Why I have to touch it? So I can still be very minimally invasive and go through no prep veneers. Many patients in Italy like to know and think that nobody knows they got crowns or veneers. So for us, it's cool to be like have beautiful teeth, but not too beautiful. The Hollywood smile, maybe they're starting now, but the Hollywood smile is something like, oh, look at him. He's got white teeth like a tub, like Pozzi Ginori is a ceramic for tubs for the bathroom. So, you know, right? So we still have people, cultural people, that they want these kind of things. And now this guy would love to do again the veneers a little bit lighter, a little bit whiter, but it's too late. And anyway, we have a compromise. Yes, I didn't go through the gingival manipulation here. I had, when you have undercuts, for example, we have protocol, but under rubber dam after cementation, you have undercuts. So the option is, before doing the preparation, before doing the impression, you prepare the tooth in order to avoid the undercuts when you have triangular teeth. Or you can fill the undercut with composite in order to avoid the undercut. Or you can decide, in other cases, to have a lingual veneer, composite veneer, and then cement on the buccal part the final veneer. Sandwich technique, Vailati technique, whatever you want to call it. But we have protocol, so it's quite predictable, and it's perfect for mid-age patients. Another patient with abrasion, fracture of the teeth, we have to work on vertical dimension. It's a lot of work, but no prep. Again, I've been cleaning up, yes, of course, a little bit, but without removing healthy soft tissue, healthy tooth enamel or dentin. And then we have overlay veneer, no prep veneer, whatever you want to call them. There are layers of ceramic I can add on my teeth, very, very predictably. Additive works up, enamel in the cervical area, sometimes we don't have it. It's a limitation, yes, but we can still achieve beautiful results. I only had a failure from this technique at the moment, and it was from a patient from Russia. She came to Italy to do the veneers. She go home, and then after a week, she sent me a picture with the veneer in her hand, and I was shocked. But it can happen. We know that we do no prep, the adhesion is lower than when we do prep, a minimal prep on the enamel. If you treat the enamel, the adhesion will be better. We know if you don't prepare, we have undercuts. We know that if you have no enamel in the cervical area, we can have a problem. But I still go through this because I know that with all this limitation, I can still achieve beautiful results with this unpredictability and, above all, preserving as much as possible the biological structure. This is my philosophy. I'm not saying I'm good, I'm not saying I'm right, but this is what I would like to do. So we have additive works up and over contour, and again, teeth, for example, in this case, we have misalignment of the teeth. I don't want to touch them, and we can compensate with additional veneer. So we can recreate the space and position in the teeth, a new shape, new color. Why not? Okay. And after 40 months, now I have a follow-up after 80 months. They work very well. Sometimes, I told you, because it's not something bad. Everybody's got failures. If you don't have failures, I don't believe you. It's impossible. But I'm trying my best to reduce as much as I can the failure, following the protocol, and be honest with myself and with the patients. After 40 months, again, beautiful gingiva, no problem at all. Of course, again, don't think about veneers, prep or no prep. Just think before the veneers in the frontal area, when you create longer teeth, think about function. Because function is fundamental. And aesthetics without function is really nothing. So be careful, please. So we go through the concept again. And again, we have patients that don't want anybody to know they got crowns. So we try our best to make it as natural as we can. Okay, this is what I call B.O.P.T concept in an prep. Well, and again, when we go through the cementation, look at this. In a 50 years old people, most of the time, the cementum enamel junction, because the brushing, because the time is not a huge information anymore. So I just want to recreate this information a little bit more epical, without invading, or try my best not to invade the circus. Okay, it's not easy. Sometimes cementation is kind of a mission impossible. But at the end of the day, we can try our best to cement and recreate a new cementum enamel junction, a prosthetic cementum enamel junction, nearby the old cementum enamel junction. And in this way, we can actually achieve, I say, beautiful aesthetics. I'm going to show you one more case, and then we get for a coffee, okay? This lady, she wants to change her smile. She has beautiful teeth. She's trying her best to come to my office and ask me to do something. But I really didn't want to do this, because it can be very dangerous if you touch beautiful teeth. So at the end, we decided together, after the diagnostics, we decided to go through no prep veneers. And again, is a compromise? Yes, of course. But I feel comfortable anytime I do not damage, biologically speaking, my patient. And nobody can take you to the court for that, because you've been trying your best. So I do my smile design according to the project. I want to go through the no prep veneers and see the lady when she's smiling on the specific position of the mouth. You cannot see her teeth. She's been trying everything, injections, whatever, botuline, but nothing works. So she got through the teeth, and with the mock-up, as you can see, she's happy. So it's up to me and to the patient. I want to meet her expectations. What I do now, after the mock-up, I go through the no prep veneers. Because I think, again, key to understand um, the B.O.P.T concept is the over contour, the new over contour I'm creating, and where I know that the soft tissue is going to respond to. So I've got the case acceptance through the mock-up, and again, do not forget, we always have to work on vertical dimension. So before getting into the treatment, doesn't matter which kind of, we have to make sure that from a function point of view, we are fine. Otherwise, we are in trouble. So with the mock-up, I'm pretty confident I can reestablish a proper vertical dimension according to the final aesthetic solution. I can check the occlusal patterns, so I know exactly the amount of ceramic I need to finalize my case. I know which are the occlusal patterns, the occlusal guidance, lateral guidance, with a test drive, with a mock-up. So I like to think like this, and I think I'm pretty safe anytime I work like this. Test drive, occlusal, posterior, lateral guidance, canine, and anterior guidance. When everything is set, I can go through the final impression, put a little bit of anesthesia, okay, and these are the veneers at the day of cementation. Very hard. The hardest part, I think, is how try our best to do the cementation. X-ray before and after. And as you can see, we have thin layers of ceramics, intimate adhesion to the teeth, and again, is a compromise. Yes, of course it is. Look at this. Sometimes it's not a defect, it's just the additional ceramics we've been placing to recreate a new shape of the tooth, a new dimension. And if you look at the occlusal part right here, of course we have kind of imprecision. But you can't do any better. It's very difficult. It's very difficult. So in time, we have to follow the patient. It's a compromise, yes, but I like to think like that. This is my philosophy. I want to be minimally invasive. And the rubber dam, the clamp of the rubber dam can damage the soft tissue, yes. See after a few weeks, but if you wait, then it's going to be fine. Because we know we've been creating a new prosthetic cementum enamel junction. So, no problem at all. Okay, night guard, think about the function, and we get to the final ceramic with a new vertical dimension. Look at here. Of course, we need to work in a completely different way. But it works. I like it very much. Patients are happy. So I've done many cases like this, and they love it. Okay? Now, we can take a break, and after the break, if you want, before we start again, you can ask me questions about the B.P.T if you want.